Hello, class. Welcome to Podcast 3. My name is Rajesh Jacob. Hope you all had an enjoyable long weekend. For this week, we'll be discussing on the following topics: pain management in geriatrics, pharmacological and nutritional concerns in the elderly. In my opinion, the symptom of pain is one of the most challenging presentations to a clinician. Challenges presented are many: obtaining objective information regarding pain, measuring and comparing outcomes, locating a source of pain or the cause of pain, providing prognosis on the condition, availability of clinical predictors, cognitive status of the patient who is reporting the symptoms, and some cultural or religious beliefs. For example, there are certain cultures that believe that pain is a punishment from God, or there are certain other religious beliefs that um, believes that pain is a form of suffering that is taken by human beings for a good cause. Either way, these could be factors that affect the subjective reports of the symptom. All of us know about various assessment methods that we have to assess pain. And it is often difficult to come into a conclusion as to what is the causative factor behind it. But apart from the assessment, what could be an effective approach to stop the pain? And what could we as physical therapists do to make a difference? Often, if pain comes from a singular source of pathology, like tendinitis or bursitis, or if pain is from um, a surgical procedure, the outcomes can be predicted easily. However, on the contrary, if it is from an unspecified origin, both diagnosis and any relevant therapeutic intervention becomes challenging. Though patients in Canada have the privilege of direct access to a physical therapist, it's not unusual that the third party funder would ask for a physician's prescription with a diagnosis on it. And it's very common for the patient to then walk in holding this note in the hand that says physiotherapy for lower back pain. Some physicians would add another sentence saying, at the discretion of the therapist. It's even more saddening when physicians would add even further directives saying only 12 sessions of ultrasound therapy, or some other directives would say no aggressive physiotherapy, or sometimes they go into say core strengthening. Earlier on in my career, when I graduated as a new grad from school, when I felt all empowered to make a difference in the patient's life, the early strategies I used to use for pain relief were um, thermal agents, maybe mobilizations or modalities. What I noticed was the patients reported an immediate relief, but they would come for recurrent visits. They almost felt dependent on me for them to manage these symptoms. And of course, with each added visit, they were quite disappointed with the recurrence. The joy and the happiness they had from my services during their initial first or second visit started to kind of reduce, and it rather became a disappointment when they had to repeatedly depend on me for pain relief. But down the road, nowadays, I believe a lot in educating the patient regarding self-management. I often encourage activity, and I discourage the patient from catastrophizing their symptoms. And I often encourage coping mechanisms. And I often tell them, don't spend time describing the pain to me, but instead, I would like to know what your coping mechanisms are. When you felt that kind of burning pain, nagging pain, debilitating pain, what did you do to get over it? There is a study and research indicating that most of the physiotherapists presently in practice do not use a cognitive based behavioral therapy approach to pain management among physical therapists. This is cited from a physical therapy journal, the reference which I've included later on. The striped bar to the left indicates the number of physiotherapists or the percentage of the respondents to the survey, which were all physical therapists, who are already using cognitive based approach to pain management. The blue bar represents the percentage of respondents which were physical therapists who are interested in knowing more about cognitive based behavioral therapy. And the dotted bar indicates the percentage of respondents who were not interested in using this approach at all. In my opinion, I think more and more physiotherapists should take the route to cognitive based behavioral therapy for long term effects in pain management. Polypharmacy, or multiple medications being given to the elderly, is another um, topic of discussion which I would like to present this week. Boisno, in his text, which says primary care for the physical therapist, mentions that presence of multiple diagnoses in the older adult leads to complex pharmaceutical management, and especially in the elderly, pharmacodynamics, which is the intended action of drugs on any individual, it may be either exaggerated or reduced. So, especially with the elderly, giving them multiple medications, I think physicians and pharmacists should screen the patients strictly before any added prescriptions are given to the patient. I like this slide that I came across on the internet during my research, and it's quite hilarious where it says each capsule contains your medication plus a treatment for each of its side effects. This graph indicates the adverse reactions of medications, and it indicates how steep it becomes, how much it increases with the added number of drugs taken. One of the adverse reactions of multiple medications uh, that the elderly take that I would like to present today is falls. Um, while screening the elderly patients for the list of medications taken, it's very important to look for adverse drug reactions. In my experience, there is a direct correlation between the symptoms that they present with and the number of drugs that they are on, and especially if if these multiple drugs have, various drug interactions. Falls in the elderly are a common adverse drug reaction that I come across with, and especially those of whom who are taking medications that are antihypertensives, hypoglycemics, some anti-Parkinson medications, antidepressants, anticonvulsants, and also, especially, the elderly population that are dependent on opioid medications. The questions for this week, what I would like to learn from all of you is: one, discuss a pain management strategy that you have found useful in your practice while caring for the elderly, especially those with comorbid conditions. Second question, what are some of the effective marketing strategies physical therapists can employ to promote ourselves as an effective alternative in reducing pharmaceutical dependence and consequent adverse drug reactions. Sorry, here are my references, and thank you.